Hi, everyone. Thank you so much for joining us today on Wednesday, March 8th for today's session on nervous system exam and common findings. We're going to follow the same format we do each week. I know we have a lot of people joining us that have joined us before, so we're going to start with introductions and announcements, followed by our didactic, and we'll have a case discussion throughout the series, and then we'll end with closing and reminders. Just as a reminder, you are all muted upon entry, so if you do have a question, just feel free to unmute yourself and introduce yourself before asking a question. We are CME accredited, and this session is accredited for 1 CME credit by the UC Irvine School of Medicine. And just as a heads up, the California Board of Registered Nursing does recognize CME credit as transferable for their members. This project is supported by the Health Resources and Services Administration, and this information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. We're going to do some quick introductions. If you are here with us today, please go ahead and just introduce yourself in the chat with your name, your role, your site, and your location. We just like seeing where everybody's from today and everyone that's joining us. And also just so we can make sure to mark your attendance. If you are going to receive CME credits, please do introduce yourself. And we'll go ahead and have the team introduce themselves. My name is Nika. I'm the project manager for our Geriatric Workforce Enhancement Project. I'm here at UC Irvine in Orange, California. And I'll go ahead and have Dr. Segal introduce herself.
Welcome, everybody. I'm Sonia Segal. I'm a clinical professor here in the Department of Medicine, and I work in the Division of Geriatric Medicine and Gerontology at UC Irvine Health. And it's my pleasure to welcome you today.
Thank you. And PA George?
Hi, I'm Valerie George. I'm a physician assistant, and I work here at the Senior Health Center and doing outpatient geriatrics, and glad to be here with everybody, and hope you enjoy the lecture today. Thank you.
Thank you. And Dr. Pereira?
Hi, everyone. I'm Manisha Pereira, one of the assistant clinical professors here at UC Irvine. Welcome, and I'm happy to be here today.
Thank you so much, Dr. Pereira. And we'll go ahead and have Dr. Tam take it away. He's going to be presenting today on a review of the nervous system exam and common findings. I'll go ahead and let Dr. Tam share his own slides. Give me 1 second, please.
Thanks, Nika. Can you hear me? Okay.
Yes, we can hear you.
Okay. And then, oh, shoot. I can't see the screen on here. Can you see the like the slides in present mode?
Yes.
All right. I'm gonna zip forward back here. So yeah, once again, my name is Steve Tam. Thanks for having me. I'm one of the geriatricians here at the UCI Senior Health Center. So I was asked to present on and go over and discuss, review the nervous system exam and some common findings, which is a pretty broad topic here. So, you know, at the end, feel free to ask questions. I think I'm going to try to cover some of the things that I think that as everyday clinicians that we typically look for, that we might spot or find. So I think that those are probably the key relevant pieces. So, but if I miss anything, please feel free to ask. Certainly it's a, again, pretty broad topic of discussion present on there. So the objectives for today, we'll go over a case, beginning and end, and we'll talk about some of the key components of the nervous system exam. We'll talk about the kind of the use of the neuro exam. I think the important part of this is that, you know, again, the neuro exam is pretty broad. You have a lot of individualized tests that you can focus in on certain things more. So it can be fairly overwhelming if you're trying to just do a nervous exam when you're a medical student or an intern or resident and you're attending ASCU. Most of the time, I think in daily practice, we probably do more of a focused exam based on what a person's complaints might be. We might expand upon that, look for other associated findings. or have them kind of come back in the next time and then follow up on that. So I think that that's a key thought, that we don't need to do necessarily a full complete exam every single time. And some of it we can be directed by, what the circumstances are, what the context of the situation is, to kind of help us be able to do things in a timely fashion as well. Not that it isn't important, but that way it can help us focus more. I actually do am part of the Alzheimer's Research Center here. And some of the clinical trials that we actually do pretty rigid complete exams. So they're very structured, and I have to capture all the different components of it from beginning to end. And so it's pretty repetitive for that. But at the same time too, I take out a lot of the other things that I'm not worried about in terms of the exam, because I'm just doing them from a research standpoint. So those are things to kind of factor in and keep in mind when you are doing a neuro exam. Okay. During the course of the discussion, we'll point out different findings / what to look for during the neuro exam to help guide us as well. So this is a real case that I had this past year, actually. And she is a 68-year-old recently retired social worker who came to me. She was looking for advice on this because she had gone to her primary and then couldn't really find anything, or really didn't get very far. But she had been having about 2 months of kind of a more or less progressive numbness in the hands and feet. Doesn't really complain of it as pain at the time, but numbness per se. When you kind of query her a little bit further, she says that her walking, her balance have been really off the past 4 months. No falls associated with it, but it doesn't feel good when she walks. Is the only way that she can really describe it. Okay, so no pain. She didn't really think that she was weak per se. It's just when she stood up, she felt like she can go either way pretty easily when that's the case. She didn't have an associated headache, no vision changes, no swallowing changes, not really dizziness or vertigo per se. She didn't have any chest respiratory symptoms. She does have some GERD, which she was on protonics for, but otherwise no real gastrointestinal or urinary symptoms. Her medical history was notable for hypertension and gastric bypass, probably about 15 years ago. She was on amlodipine, telmisartan at the time, pantoprazole. She was on meloxicam. When I asked her about the meloxicam, she didn't really know why she was on it. She couldn't really tell me. I asked her if she had arthritis. She kind of denied it too. Later on, I'll go on to say that, when you look at her knees, you could see a lot of arthritic type changes in her knee, various changes, kind of the hypertrophic arthritic type appearances to it. But she denied it, and she didn't really complain about pain for it. And so really the meloxicam, I think, was just kind of masking it at this point. Once again, she's a retired social worker. No alcohol, no smoking since college. She drinks coffee, probably about 2 to 3 cups a day. Mother had a history of gastric cancer. Father died at 50, unknown causes. Suspect it was probably heart related. So when we did her exam, the non-neuro part, her head and neck exam, her cardiac exam, her pulmonary exam, her abdominal exam, skin exam, really not without any localizing findings of like rash or other kind of changes on there. Once again, she had arthritic changes in her knees that I mentioned. No effusions, no edema, no redness, anything of those sorts on there. Then her vital signs are generally pretty okay, non-significant findings. Sorry, I just killed a mosquito on here. Ooh, yes. She weighed about 167 pounds at this time. And then, let me see. Oops. So going to her neuro exam, I will save the neuro exam for kind of the details of the neuro exam for the end, after we go over some of our discussion points, so that we can delve into it a little bit more. But some of the teasers for it was just that she was alert, she was oriented appropriately. I'll leave the rest in terms of how I documented this in place. Her sensory exam, I'll just say that she had decreased sensation in the lower extremities, I had her do some blood work that day, noted to have her white count of 2.8, a hemoglobin of 8.4, low hematocrit. Calcium was on the lowish side with all this. And I'll reveal the rest of the exam towards the end here. So if you look at the neuro exam, these are probably the key components that we should kind of be on the lookout for. Again, we may or may not be doing all of it depending on what the situation is, what the context, what a person is coming in, and what they're presenting for. But these are things to really keep in mind. I think the other part about the neuro exam is really a good majority of it is that we just need to observe to see how a patient is when they come in the room, really. Some things that are kind of tricks for me is that, sometimes I'll stand in the hallway and just walk a patient as they get roomed and walk in to look at their gait. So I save parts of the exam or get parts of it done in there. So, you paying attention to like how they speak, what their facial expressions are, what, how they're sitting in their chair, how they're getting up, those are all kind of things that go along into doing a pretty good neuro exam and getting you a lot of the information in terms of, helping you kind of cut down some of the time from it. The other key thing about the neuro exam is that if you are going to do a pretty extensive neuro exam is having focus. About going from top to toe or having some kind of order to it. Once again, I think I mentioned doing research neuro exams for clinical trials on a pretty regular basis. It gets pretty tedious and it's easy to forget one thing if I don't do it by a certain structure. And certainly the forms that I have to complete for it, usually they structure it such that you are knocking out the cranial nerves, the strength, the reflexes, the sensory coordination, the gait in this fashion here. Usually mental status is kind of at the beginning or at the end, just based on how you're observing it, okay? So that's some important things to kind of keep in mind to consider. So mental status, won't delve into this. I think that there's probably been other sessions about checking a person's cognitive function and looking at mental status function. But the things that you want to pay attention for or look at is an individual's level of consciousness. Are they paying attention? Are they able to focus? Are they concentrating on what you're saying? Are they oriented to what's going on? How their language is like? Memory, you might check based on, you might get a good sense of it just by having a conversation with the person, right? Are they telling you about what's going on recently? I had somebody that was coming in and, a new patient, and you could tell that it was probably moderate level of a dementia present. I couldn't really get anywhere with her in terms of like doing a neuropsych exam. So I just kind of asked her, what was the weather like last week, right? And obviously it was pouring rain. There was snow everywhere in the mountains, and but she said, "Oh, I think it was sunny." So that gives you a good idea of of what their immediate recall, their recent recall might be. So there are other ways to assess it if you don't do it by a standardized fashion on there. So just having that conversation with somebody gives you an idea of how good an individual's memory might be or not. Looking at their higher intellectual functions, their ability to reason, what insights that they have, looking at their knowledge, looking at their mood and affect, you're probably going to gain a lot of that just based on having a conversation, taking a history for the individual. And so it might just guide you into some more of the directed cognitive testing or what other assessments that you might want to do at that point on. So things to look out for when you're looking at mental status, probably the big ones are going to be any kind of altered level of consciousness or delirium versus something that might be more associated with more progressive decline of an underlying neurological condition. So usually in a delirious state, you'll see an individual's attention really kind of fluctuate. They're hard to direct, or their conversation will be jumping all over the place. Looking at, and it may not just be delirium, it might be also part of some other conditions like a psychiatric disorder or something like that. But those are the things to try to glean and document if you can in terms of as part of your assessment, okay? So that's a mental status part. Cranial nerves, again, pretty complex. You want to localize depending on what you're suspecting in your workup. But generally speaking, there's 12 cranial nerves, and whether or not we're able to go through all of these in the right fashion, it gets to be a challenge if you aren't kind of regularly doing it. Again, depends. the main things are you're looking for any deficits that might be here. So like if you actually just dive into the individual cranial nerves, it can be sometimes overwhelming. I think the big things are, again, what are the findings that you're looking for? And usually you're looking for any deficits between the function of what that cranial nerve should be doing and any asymmetries that might be present on there, okay? So if you just start from the first cranial nerve and work your way up to the 12th, you kind of go over what the function, what they're supposed to be doing. So, you know, the first nerve is the olfactory. You know, we don't have a lot of noxious smelling stuff in the office to kind of smell, but you can kind of get a sense based on the history how they're doing with it. You can have certain things in the office to help test it. I don't know that we regularly do in terms of stocking our offices with things to smell, but you can have them smell like coffee or, you know, other things like that if you really want to delve into it. You do want to make sure that there's no like obstructive sinuses or nasal turbinates or something like that that's really bogging it down, that, you know, might be confounding the picture if that's the case. And, you know, you might get into checking one nostril versus the other, okay? When you start getting into the optic and the eye muscle, ocular motor muscle, cranial nerves, that's going to be your 2, which is your visual acuity, and then your visual fields into your 3, 4, and your 6. And that's going to be your ocular movements. Know that you're involving visual acuity and visual fields when you're talking about 2 here. 2 and 3 kind of work the pupil sizes, and you know you're looking for any asymmetries, changes in reaction to light present. 3, 4, and 6, these are from like med school days or education days in terms of knowing where all these muscles control and the different ocular movements on here. But you know, it's diagrammed out. The main things, the key parts of this is to see if those ocular movements are moving smoothly in all the different fields, and whether or not there's a defect in one eye versus the other, or, you know, both are moving in concordance. If there's presence of any saccades / nystagmus, if it's beating back a whole lot more, then again, it tells you that there might be some presence of something that's affecting those cranial nerves in that case. And again, it depends on what you're trying to look for and working up. You know, usually if somebody tells me, and again, I'm not an ophthalmologist, but, you know, so I'm not as experienced in terms of like having a deep look in the fundi. I think we can get a good sense of what the fundi probably should look like, but if we're doing the otoscope, ophthalmoscope, we're probably looking, you know, the key things to kind of spot in on might be any hemorrhages, extra vessels that don't look like they should be there, things like that, I think are key. You start getting into the 5th cranial nerve, the trigeminal nerve. So this is probably the most complex cranial nerve. It's made up of kind of 3 big branches: the ophthalmic, the maxillary, the mandibular. You know, so the ophthalmic and the maxillary are primary sensory. The mandibular is sensory and motor. And you can check the mandibular by having them bite down, getting their masseter strength here, versus cranial nerve 7 and the facial nerves, where you're going to have them puff out their teeth and push against. So it's going to be a difference in those nerves there. But with the trigeminal nerve, otherwise you're checking a lot of sensory components to it. So this is just a breakdown. The yellow is going to be your ophthalmic, the green is going to be your maxillary, and then the orange is going to be your mandibular nerve. And the mandibular nerve also has part of it, taste and the tongue involved in the anterior 2/3. I have to look up which all the different sour, salty, sweet tastes in terms of what are involved with it. Again, we're probably not going into all of that detail, but there are reference points for that if we need it. If there's any deficits here, we might progress further if we're really worried about the trigeminal nerve and look at the jaw jerk or the corneal reflex. I have not done a corneal reflex since medical school, just because, and in that case, it was actually somebody that was in the hospital, had a pretty severe stroke. I remember that pretty distinctly. This is not something that we do on a regular basis with it, but it might help guide us if that's the case. Cranial nerve 7 is going to be your facial nerve. I skipped 6 because that was part of the extraocular movements, or or the ocular motor movements, and we covered it there. But 7 is the facial nerve, primarily going to be controlling the muscles for facial movements and expression. You're looking at the movement of the forehead, the eyebrows, the cheeks, like I was mentioning, in terms of puffing. The big thing might be to look out for like a Bell's palsy here when it involves just one side unilaterally. It'll point typically to the facial nerve or cranial nerve 7. The 8th nerve is the auditory nerve. Again, in our older patients, this can be kind of tricky. You get some hearing, but you can do a finger rub or other ways to, or like a whisper test to see if they can hear you or not, if you don't have like a full-on checking the audio tones in the office. And again, make sure that there's no obstructions that are contributing to it too. The 9th cranial nerve is the glossopharyngeal. So this is sensory and motor. It often works together with the 10th cranial nerve, which is primarily involving the parasympathetic system. But with the 9th, you're pretty much looking at the motor function involved in swallowing and the palate. So having them open their mouth, say ah, and then watching the palate elevate and looking for any asymmetries, checking their swallowing function with water or whatnot, looking at the quality of their voice. Sometimes dysphonia might involve this system here. A gag reflex would involve both of these if really need be on there. And again, that's another one where oftentimes we're not checking a gag reflex on a regular basis per se on there. The 11th cranial nerve is the spinal accessory nerve, and this is innervation of the trapezius and the sternocleidomastoid muscles on here. So really, this is your test to check for shrugging of the shoulder, turning your head against the hand this way, and checking the muscle control, looking at the muscle contractions on the muscles here on the opposite side, and vice versa here. Okay, things that really would affect this typically would be any kind of injuries that might happen, trauma, surgeries that involved any kind of like neck dissection, lymph nodes or whatnot. So it really depends on where the extent of the procedure or trauma is occurring on there. If the CN11 nerve is affected, impacted over a longer period of time, somebody might present with torticollis because they lose the opposing contraction of one of the sternocleidomastoid muscles. So one side is just pulling versus the other. So if it's just pulling here and this side's not counter pulling, then I'm going to be stuck on one side and getting torticollis as a result of that. Okay. Cranial nerve 12, the hyperglossal muscle, involves the tongue. And so this is the one where you're going to look at the position of the tongue, if it's deviating left or right, how strong is it when it pushes against the cheek on there. Things that might affect this might be any kind of motor neuron lesions in terms of checking this here. Okay. I see some questions coming up in the chat. I'll get to them and I'll towards the end on there. Okay. Things to look out for. So the motor strength exam, usually you can follow that next. But things to observe, look at. In terms of doing this, again, observation is a key part, looking at the bulk, the amount of muscle mass that's there, looking at muscle tone at rest, comparing the left to the right, looking at distal and proximal, upper to lower extremities, how quickly somebody's moving. And once again, you might glean a lot just by looking at how somebody is moving as they walk into as they get roomed in your office. Okay. If you're checking muscle strength, sometimes if you might have to isolate the muscles right? If just to help identify what the biceps is doing or triceps is doing, we're taught usually you kind of hold them by the elbow and then have them bend against to help isolate what the biceps is doing rather than giving them leverage from the shoulder or other groups on there. So fixing the proximal joint and then testing distally on there, making sure you have the advantage. There's going to be some variability in terms of the size of the individual, how much older they might be, if they have some other changes like arthritis or other things that might be affecting how strong that they can be, whether or not they have a giveaway weakness that's present on there. So some key kind of muscle groups to look at would be at the deltoid. So this is with abduction of the upper arms on there, biceps, flexion at the elbows, triceps, extension at the elbows, extensor carpi radialis, flexion at the wrists on here, dorsiflexion, abductor pollicis brevis versus abductor pollicis longus. That's when you have your hand, I'm trying to put it in the camera here, but if your hand is flat and this thumb goes straight up, this is that motion right here versus this action where it comes straight out on it. Okay. So those are what that indicates in terms of the nerve distributions. But with this one, if you've got somebody that you're suspicious for carpal tunnel, you might see them not being able to do this function here. I actually can't do it very well myself. And then the interossei muscles, their ability to spread their fingers versus closing their fingers. If you've got a resistance in there, that gives you an indication of their ulnar nerve if you're worried about any kind of a compressive ulnar neuropathy or something. Some key lower extremity muscles, hip flexion, knee extension, knee flexion, ankle, dorsiflexion, ankle plantar flexion. Those are all ones that you're probably checking if you're looking at the lower extremity strength on there. Those are the nerves that where it correlates back to. Getting into reflexes, keep in mind that as we get older on there, other things can really also be affecting that reflex arc. So different things can contribute to it. With age itself, some of these sensory fibers, they might slow down in terms of the way they're firing. And we know that, we see less of a plantar reflex, things like that. They might actually be affecting our ability to control ourselves as we walk, maybe contributing to falls or whatnot. Main ones to really check are the biceps, the triceps, the patella, ankle reflexes, ankle jerks. Again, not that we do these all the time, but if you're worried about like certain upper motor neuron lesions versus, if somebody's presenting that way, that might be the time to check these different things. You're looking for any asymmetries that might be present. Sometimes it's hard to get people to get the reflexes out of them. So a couple of things that you could do is distract them by having them do something else. And as you do it, you tap the reflexes. I like to have them contract sometimes other muscles. I have, like if I'm not getting a good patella jerk or patella reflex on there, I have them put their hands together like this. And when I count to 3, I have them pull on each hand, so that way I can have them contract these other muscle groups and then relax the lower extremities when they're doing this, and then I'll get potentially get the reflexes to come out. Okay, grading it, sometimes it's hard to remember. I think the easiest the way to do it in terms of a scheme is just go at the extremes and find the middle. So knowing that 2 is the normal, and when you're grading a reflex, 2, and that 0 is absent and that 4 is really, really hyperactive, then you kind of know from there 1 and 3 are in between. So a little bit less active and a little bit more active, more brisk from there. So that's an easy scheme for us to remember if we need it. A couple of other types of reflexes that we're looking for, the plantar or the Babinski reflex. We're really looking to see if the toes are flexing down. If you do stimulate them, the bottom of the feet on there. If you do, and the big toe dorsiflexes goes up, the other toes fan out. can be indicative of an upper motor neuron lesion. Other kind of primitive reflexes that might pop up, usually, they're probably not going to be on a regular basis, but they might show up in somebody that has a pretty severe dementia that's progressed for quite a bit, or if they have any stroke or mass lesions. Sometimes we might see this in the hospital when they've had something major or catastrophic happen. But what happens is that some of the upper motor neuron controls get removed, and these reflexes pop out. So upper motor neuron, lower motor neuron, always a confusing kind of thing to remember. The one easy way to think of, so what it is that upper motor neuron is just usually anything above the anterior horn of the spinal cord. So parts of the spinal cord along with the brain, and then also before it hits the cranial nerve bundles on there. And then the lower motor neurons are the neuron components that are below that anterior horn. Okay. But usually, if you think of it this way, upper motor neuron with a stroke or a brain tumor or something like that, you're essentially taking away that cerebral control. So kind of the basic or the other reflexes will come out as a result of this. Okay. So that's kind of an easy way to think about it in that sense. Sensory, some considerations. Making sure that you try to explain the test if you're gonna, poke them with something sharp, with a pin. If you're gonna test them with something cold or something hot, the vibratory, the tuning fork, usually just try to explain to patients what we're doing. Having them close their eyes and not seeing what you're doing, I think, is important. Testing all the extremities if you do need to do so. Avoid leading questions. And then comparing side to side, mapping out the boundaries. Usually you kind of start distal to proximal to help to check it, because that's usually where the site of breakdown or degeneration happens the most, or earlier on, and then works its way up. The main senses to be checking would be pain, light touch, vibratory, and proprioception. The kind of more complex senses to test would be, again, if you suspect something more complex is going on, you could check for graphesthesia, stereognosia, double simultaneous stimulation. What those are is, with graphesthesia is where you take like the hand, let's say, and you write, you have them close their eyes, you write a number on it or draw a shape on it and ask them to tell you. So these are, you're checking the senses integrating with the higher cerebral functions and the ability to sensitize all this information, whether or not that connection is working. Okay. Graphesthesia would be that. Stereognosis would be if you put an object in their hand, and whether or not they can sense what it is. So you close your eyes, you put a coin in their hand, a fork, a spoon, something like that, and they can make out what that is. Double simultaneous stimulation would be checking senses kind of at the same time, both sides. Usually if there is where only one side is sensed, then it could tell you that there's probably more of a unilateral problem in terms of what's causing the sensory problem on there. Okay. Big thing about what to look for or what findings might be present on the sensory exam is really for the pattern and the distribution of what you're finding. Is it a polyneuropathy? Is it the classic kind of stocking glove distribution that fits with like a diabetic person? Is it a focal neuropathy / in a radicular pattern, something like that might be present with the median neuropathy or an ulnar neuropathy? Is it distal versus it only affecting proximal? Does it involve like cranial nerves, or what's the extent of it? Those are the kind of questions that you're going to want to be looking for to kind of help guide you if it's as the cause of this, really. Okay. So yeah, once again, the different types of the primary senses that are really checked, pain or temperature, you're checking for a gradient, loss in the leg. Some key nerves to be looking at would be the median nerve, the ulnar nerve, the radial nerve, L5 and S1, comparing left to right, like we mentioned on here. With light touch, usually, again, checking face for that cranial nerve 5, extremities, working distally to proximally, confirming that they're actually feeling what you're touching with. Vibratory sense, using a tuning fork. This is one you could start again distally and work your way up proximally. Seeing when it extinguishes might be a sign of different kinds of neuropathy with the vibratory and working it out on there. I don't, with the vibratory decreased sense, again, there might be other things that impact it, especially if somebody has had like injuries to extremities or bony injuries or other things or whatnot. So those are other things to kind of keep in mind with this here. The double simultaneous extension, again, like you're having them touch, you're touching both hands at once or both sides of the face at once, seeing if only one side is felt versus both. It's one might point to some unilateral brain damage, usually in the parietal lobes, if that's the case, that's causing that. Okay. Coordination. Primary things to be looking for with this are presence of any tremors as you're doing these, or dysmetria. Dysmetria is the ability to control the range of movement. So when they do the finger to nose, you're really going past the point where you should be stopping. So that's what they mean by past pointing. But these would be more indicative of a cerebellar problem if dysmetria is present. The things that you're observing for or looking at are the control and precision, rhythm and energy of the movement as you're doing the exam. Okay, doing it at rest, in movement, are ways to conduct it as well. But I think the primary ones to be checking would be finger to nose movements, finger to nose, back to finger. I just distinctly remember a patient one time that had some dementia that was pretty significant. When I had them try to do it, they try to touch my nose. So it's also can give you an idea, again, if you're observing, like what their level of comprehension and everything is. So it all kind of ties back when they have them do that. But rapid alternating hand movements, heel to knee to shin. Keep in mind for those that have like arthritis, they may have difficulty doing that procedure or doing that task. Finger taps, toe taps are also other ways to check coordination. Gait and station. Again, a lot of observation, looking at an individual's posture, looking at their length, their stride, how quickly they're walking, their rhythm. Are they wide-based? Are they narrow-based? How steady they are, looking at their arms and their ability to swing, all factor into different kinds of gait patterns. Orthopedic gaits, antalgic gaits, sometimes we'll typically see in our older patients that have hip and knee problems. Hemiplegic gaits if they've had stroke, the cerebellar gaits, magnetic gait might be consistent. Magnetic stomping gaits, you see a little bit more in people that have other conditions like NPH. An apraxic gait. So some of our patients that have dementia that are a little bit farther along, moderate, severe, they may have trouble figuring out how to step and get their feet to move. So they look like they can't operate or walk accordingly. Not that they're stuck, they just don't know what to do with their feet is the thing. And then you have your Parkinsonian gaits, which is a little bit more shuffling, it's slowed. They're not smooth when they make their turns. So, typically we'll have patients do a normal walk, look at them and observe them as they walk normally. Like I said, I just kind of watch them as they walk into the room so that they're not kind of on their best behavior per se. And then we can kind of see how folks are doing in their normal kind of walking stance. Their ability to walk on their toes or heels, tandem walking in a straight line, making sure that they have if they have an assistive device and if they need it, use it, document it. There's a good YouTube link on here showing where there's a doctor who demonstrates the different types of gaits. So I just threw the link on here, but we won't have time to kind of go into it. And Romberg sign. So the Romberg is really not a cerebellar test. It's a test of proprioception. So normally when we stand up, we're sensing the ground. Our eyes are also sensing the ground too, or because you're getting that visual input and stimulus. So this tests the ability of the nerves being able to tell your position rather than the eyes. So what happened, the way you do the test is really you have them stand together with their feet together, eyes open, and then you have them close your eyes. You're there to support them just in case, of course, right? But if they start swaying or they're looking like they're falling when you ask them to close their eyes, it tells you that the proprioception or the vestibular system is impaired, not necessarily the cerebellar function on there. Again, cerebellar is usually to help you control your movements, not giving you the sensory input per se, okay? And then just some other considerations when you're doing a neuro test, a neuro exam, meningeal signs. If you suspect meningitis in somebody, you're going to get that knuckle rigidity, neck mobility is going to be painful. There might be some other symptoms of Lermite sign. I've had meningitis once. I definitely had this like knuckle rigidity. I had like the shooting kind of pain, electrical pain down my back and through my leg whenever like the car would go over a speed bump. I remember that pretty distinctly, having that. Most common neurological conditions with aging are generally going to be Alzheimer's and other dementias, Parkinson's, stroke, epilepsy. I mean, there are other things that happen, of course, and they're more common to be seen as a person is older versus younger. But these are probably the ones that we'll usually encounter the most frequent on here. And some things to keep in mind with Parkinson's and Parkinsonian syndromes are really, looking for tremor, that bradykinesia, that rigidity, muscle rigidity, the posture, the balance, the speech and change, maybe having them write, looking for changes in their writing abilities, facial expressions. Alzheimer's is generally a progressive neurodegenerative condition, can have all sorts of progressive findings. There was a comment on providing more information about loss of smell, known as anosmia, as a key sign of Alzheimer's related cognitive impairment. I think that's one thing that we've kind of looked at and tried to figure out how reliable in terms of it telling us. But a lot of times too, there are other things that go into it. I think that it probably is, has some value in terms of what a patient is reporting. But I think, guiding you into doing further workup, I think that's probably where I would use it the most in terms of having that information or asking that question. But the problem is that especially here in California, we got all sorts of like sinus and other allergy type problems. People have all sorts of changes in their sense of smell, taste as well. The reflux is another contributing condition. So when you put it all together, sometimes it's hard to kind of sort that out on that basis alone on there. But if we can isolate it and get it, sometimes it is a helpful piece of information on there. And then we'll go back to our case presentation of our social worker who had this 2 months of numbness in the hands and feet. We'll go over her neuro exam. So, she was alert. She was oriented to person, to place, and time. She knew what was going on recently. There was no problem with her mental status and in her ability to pay attention. Her cranial nerves were all intact. She had her strength, I would say, was actually probably 5 out of 5. She can do both sides. She was symmetric. There was no cogwheeling. There might have been a slight intention tremor as I had her do the finger to nose. She had trouble doing the heel to the shin ultimately, because I think she was having some hip issues and trying to lift her leg up. But she had no resting tremor. She could do her finger taps okay. She had a little bit more problem doing her toe taps in terms of just keeping it straight up and down. Her gait, she was wide based. She was unsteady. She looked unsure of herself, apprehensive. She was kind of tilting side to side, but it wasn't fully ataxic when you see it. She wasn't frozen by any means, wasn't bradykinetic. She just kind of, as she walked, she just kind of would go here, for a few steps and go here for a few steps. She did actually have a cane with her because she was getting more unsteady. And then I was telling her about her knees, and she had these changes with her arthritis. She really didn't notice it because she was taking that meloxicam, but her gait was also had a component of orthopedic, like she was limping on her knee as well. So it was a pretty complex gait pattern in talking and observing her. She didn't have any shuffling. She just wouldn't get into the tandem gait just because she was so unsteady and was really fearful. Her posture was pretty normal when she was standing, fair with the cane present. Her Romberg was normal. I did take away the cane, had her stand there. I put my hands by her side, had her close her eyes, and her Romberg was actually okay with it. She had absent ankle jerk reflexes, but her other reflexes were okay. And sometimes we can see that in folks as they get older on there. So on her sensory exam, she had decreased light touch, proprioception, and vibratory senses in the lower, upper and lower extremities, and the right side was a little bit more than the left. So she had that abnormal white count, she had that normal hemoglobin, that abnormal hematocrit. Her iron level was a little bit low at 27. So initially I actually got this back. I told her to stop taking the meloxicam, had her do a fit test, which was positive. She had an outside gastroenterologist. She ultimately got a endoscopy and a colonoscopy done, and it didn't actually show anything other than some inflammation present, but her iron level was low. So the really interesting thing about this was that because it was such a complex kind of case, I actually had her see the neurologist. I was referring her to that. I actually had her see the hematologist because of the low iron and some things kind of not making sense, the low white count present. Her copper level was at 2. So our copper levels are normally about 85 to 155 is the reference range for it. Her B12 actually later dropped as well. So copper level 2, I mean, we typically don't see this just because we absorb and everything, but in her history, she had a gastric bypass, right? So that's probably the source of all this. And so it's just something to keep in mind that there actually is anemias, leukopenias that are also associated with this. And so she had that. We've been replacing her copper. Not much is known about this. I think we're kind of getting more and more information. Again, we did all these gastric bypasses, all these surgeries on people and whatnot. And, only now we're probably collecting some of this data about, okay, what are the long-term kind of effects if they're not absorbing or if there's, not getting enough in their diet or whatever the case is. But it actually looks like a subacute combined degeneration type condition, which is typically what you'll see with the most common associated with that is B12 deficiency in terms of affecting the peripheral nerves and potentially the main CNS as well, cerebral function present. But, she's been, it's been about 9 months or so now. We had her stop the meloxicam, and then her pain in the knees really came out as a result of that. And so, her x-rays showed pretty severe arthritis and whatnot. But, we've been ongoing trying to keep her copper levels up to try to help with this. And she really hasn't had too much improvement in the neuropathy. The neuropathy did progress to have some pain. So we have some ongoing treatment for that as well. There's a question in the chat about how do you replace copper, but there is oral copper supplements as well as infusions that we're getting. So this is somebody who's getting an infusion typically for this, but her level keeps dropping. So I think she's just not holding on to it, or she's in her diet, she probably isn't getting enough. So we have to figure out what's the optimal level. Whether or not the nerves come back, don't know. Usually you have to kind of wait a year and see. I'm not extremely hopeful, but I think we have to give it some time with this too. So I think that is going to be it for me. Nika, there was a couple of questions in the chat. I think I tried to answer a couple as it is, but there was one more I haven't. Do you want to go over this last component before I answer any questions, or?
Sure, yeah. If this form is just to let you know that if you would like CME credits, to just please go ahead and either scan that QR code, or I just sent an email to everybody with those links. And we always appreciate your evaluation. So if you can also fill that out, that'd be greatly appreciated. And then we just have a few other ECHO sessions coming up on those following topics. And you should, if you are receiving our emails, you should receive the updates shortly. So just, you can click on those links when you get them in the email, and Dr. Tam will go ahead and let you answer the rest of the questions. Thank you all for attending.
Thank you. So the one question in the chat was, what we think might be the best cognitive assessment tool or recommend using MoCA versus some other. I think it depends on what your goal is, if whether or not you're doing a screen. So what your goal is, the amount of time that you might have to do it. MoCA tends to be a little bit longer, probably 15, 20 minutes, depending on how fast you are or how quick the patient might be. So it's kind of harder to do it as a screen per se. Screens, different things, including the mini cog. MMSE might be a shorter screen on there. There's the GPC on there as another option. So from a screening perspective, those might be a little more useful. I actually do like the MoCA a lot, and there's different versions out there, so that not all the animals are the same each time. So in terms of variability, because I do think it tests the different functions well. And if I can't get neuropsych testing, I will use a MoCA. But sometimes slums is another option on there. So those are a whole variety of tools. I think they all kind of answer the areas that we're trying to get at. And again, there's some different tools that are available to you. I don't know if you're, who's actually paying for the MoCA yet, and that's the other kind of factor with it. So if you want to put it in like your EMR or something like that, sometimes those things might come into play if you think about it that way. But like some other tools like slums might also be helpful on there. There's another question about the long-term use of a PPI causing copper deficiency or B12 deficiency. I don't know about the copper on there. I suspect between copper B12, it may be like, if you need the acid as a co-transporter or something like that, or it's involved in the transportation system. I'm sure I won't pretend to know the pathophysiology of those two deficiencies as relates to copper on there or PPI. Any other questions from folks?
Okay, well, I just wanted to say thank you so much, Dr. Tam. That was some wonderful information. And I wanted to let everybody know we have shared the slides with you in a PDF that you should have received the email. And we always record our sessions, and those do get sent out, every 2 weeks. So if you'd like to watch it again or share it with your colleagues, feel free to do so. Thank you so much, Dr. Tam. And we look forward to seeing you all at our next session.